one of the concerns, as I said, with current data we have, is the magnitude of clinical effect of anti-amyloid immunotherapies after 18 months. Of course, the Lecanemab dataset is really convincing. I'm not putting that into any doubt. The statistical data are clean, and the company made a big effort in transparency and in communication. So we clearly have a clean dataset, and that's a good thing after the whole Aducanumab story. Besides that, we have a 0.45 effect on the CDR-SB, and that's way below the minimal clinically important differences that were highlighted on this scale at this stage of the disease. And these minimal values have been set to be about 1 point on CDR-SB. It was actually set by a study by the industry, by Eli Lilly in 2019 on a very big NAC cohort. So actually, the clinical effect does exist, but is not really meaningful so far. So the whole discussion is around, is this a disease-modifying therapy, and will we see a bigger effect after a longer follow-up, or is this some kind of symptomatic paradoxical effect of amyloid? And 0.45 is the best we can see. This is important because, of course, we are below these minimal clinically important differences, and we will give expensive and risky medication to patients. So the whole discussion is about that. We need to, I mean, as a regulator, if I were a regulator, which of course I am not, I would ask a longer follow-up for to see if we have a bigger effect and demonstrate the disease modification property of these drugs, or just show an additional study with a delayed start trial, to demonstrate again this disease modification property of these drugs. So this could be a first thing to demonstrate that we can reasonably expect a larger effect after 18 months, and that would be a good thing. So longer follow-up, demonstration of disease modification property is clearly something that we need to do with these drugs in the upcoming years. Second is to identify the individuals with a better risk-benefit profile of these drugs. And actually, Eisai has shown us some preliminary post-hoc analysis that can help us to go into this direction. And what I found very interesting was the ApoE4 effect, because according to this post-hoc data, which as always, we need to be careful when we interpret this post-hoc data, but that's the first step. And we can see that individuals without any ApoE4 allele were more responder to these drugs. They had a better effect on the CDR-SB scale than the ApoE4 positive individuals. And besides, we know very well that these individuals have less ARIA, less side effects. So it may be something that will be interesting for us in the upcoming years. For example, target ApoE4 negative individuals with these drugs because they have a better response and less side effects. So second point, after the longer follow-up trials, we need to find the better responder, and ApoE4 may be a good thing to think of. Finally, we could also think about combination therapy with, of course, Alzheimer's disease is a complex disease with multifactorial elements, and I think now everybody in the field, including the very pro people for the amyloid cascade hypothesis, recognize that if we only target amyloid, we will not solve all the problems. And we start to see that now, even with better designed trials. We only have a 27% effect on the CDR-SB after 18 months. So we need to target more things in the disease, not only amyloid, but maybe tau, maybe inflammation, maybe some other dimensions of the disease. So we really need to move forward in combination therapy trials with, of course, anti-amyloid drugs, but also other drugs. And maybe it will be something like we've seen in oncology or in HIV development. When we target several things that are key elements of the disease, we will have a better clinical effect despite similar safety issues. So we'll have a better risk-benefit profile of this drug. So 3 elements: demonstrate the disease modification, find better responders, and try combination therapies.